Chairing of our proceedings today. I'm very pleased to be able to open this debate. I chair the APPG for sickle cell and thalassemia, and we work for better understanding of sickle cell and better treatment for those living with this condition. I'm enormously grateful to all the honourable members who've supported the APPG's work, including our late colleague, Sir David Amos, who was one of our officers. And I'm grateful to the Sickle Cell Society, who provide the secretariat function for the APPG. I'd also like to thank Parliament's Digital Engagement Unit and the hundreds of individuals from around the country who have emailed me in advance of today's debate. The focus of our debate today is the recent report published by the APPG entitled "No One is Listening," which makes a number of findings and recommendations in relation to the care of people with sickle cell. And the trigger for our report was the tragic and avoidable death of Evan Nathan Smith in North Middlesex Hospital in 2019. The coroner's report into Evan's death, published in April of this year, found that Evan would not have died if medical staff had recognised his symptoms and treated him sooner. The coroner's report pointed to, and I quote, "a lack of understanding of sickle cell disease in the medical and nursing staff looking after Mr. Smith, and a failure to appreciate the significance of those symptoms by those looking after Mr. Smith at the time." Evan Smith was just 21 years old. He had his whole life in front of him. And his death is not the only one where a lack of understanding of sickle cell and mistakes in treatment have been contributory causes. I'm happy to give way.
Congratulate him and the member for Edmonton and all the other members who have done a lot on this topic in the House. And could I also just emphasise how, despite this being a very long-running disease, we really have not paid enough attention to it at a sort of institutional level, be that at primary or secondary health care. And that's something which I think really does need urgent redress.
I quite agree with my honourable friend, and our report goes into many recommendations that could improve care. Indeed, it is a call to action. It's a call to arms following Evan's death and the deaths of others and the many near misses involving sickle cell patients. We wanted, in this report, to set out the changes needed to stop this story from repeating itself over and over again. Sickle cell affects about 15,000 people in the UK, with many more carrying the trait. Patients with the condition experience periodic crises, bouts of intense, severe pain, which sometimes require hospitalisation. These crises are treated with strong pain relief, sometimes blood transfusions, and over time they can result in organ damage, increased risk of stroke, other associated conditions, and even early death. It is therefore common among sickle cell patients to have to go to hospital regularly, to present at A&E and to be admitted onto wards. And this is an important point. For sickle cell patients, contact with the healthcare system and admission to hospital is not a one-off. It's a lifelong part of living with this condition. To prepare our report, we took evidence in 3 oral evidence sessions in June of this year. We heard from patients, from clinicians, from policymakers. We heard from Evan Smith's parents, Betty and Charles, who spoke with so much dignity about the loss of their son and about their determination to make sure that other families didn't have to go through what they have. We received over 100 written submissions, and taken together, this is the most comprehensive report on sickle cell care that the APPG has ever produced.
Just on that point,
I'm happy to give way, yes.
Thank you. And can I just congratulate my honourable friend for his leadership and commitment to this issue and his report that the APPG group has produced has really shone a light on some of the challenges faced by those people living with sickle cell, whether it's around some of the negative attitudes or a lack of awareness and understanding, but most importantly, patient care. So does my right honourable friend agree with me that in order to tackle this issue, but also some of the multiple health inequalities that exist, will require significant investment and resource by the government, but also an acknowledgement of the structural racism that also exists within the health setting?
My honourable friend makes some very strong points, and I'm going to come on to discuss some of those, including the question of race, as I continue. Since the report's publication, I've continued to receive emails from sickle cell patients all around the country which confirm the report's findings. And I want to put on record my gratitude to each and every person who's taken the trouble to write to me, whether just after the report was published or in advance of today's debate. Now, let me set out the main findings of the report for the House, Ms Miller. Let's begin with a positive. We found a good level of trust among sickle cell patients in the specialist haematology departments in hospitals that look after them on a long-term basis. We found clinicians passionately committed to better treatment and honest enough to tell us when that good treatment wasn't there. We found that where there's a good level of understanding and knowledge, sickle cell patients are generally well treated and well looked after. But we also found a huge gulf between that good level of confidence and trust in the specialist parts of the system and treatment in the more generalist parts of the system, specifically A&E and general wards. Now, our key findings include unacceptable variability of treatment depending on where you live or who happens to be on duty at the time. Patients having to battle for the pain relief to which they are entitled. Protocols on pain relief. For example, that it be administered within 30 minutes of arrival, regularly and repeatedly ignored or not implemented. Witnesses told us of waiting for hours in excruciating pain. Some clinicians spoke of adherence to the pain relief guidelines within their own hospital as being as low as just 20 or 30%. A lack of compliance with care plans which had been agreed for individual patients, including sometimes agreed with the very hospital where the patient had turned up, being ignored, or people being told that doesn't apply here. A dangerous lack of communication between the general and the specialist parts of the system. For example, in Evan Smith's case, he'd been in the hospital for over 2 days before the haematology unit even knew he'd been admitted. This was a finding described as shocking by one haematologist who gave evidence to our committee. Delays like this can contribute to mistakes with the most terrible consequences. And as well as deaths, as I've said, we heard about a number of near misses where care had gone badly wrong and the patient had still survived. A lack of awareness of the condition and a lack of understanding of how to respond to a sickle cell crisis among some NHS staff. Everyone in the healthcare system knows the key symptoms of a heart attack or a stroke and how to respond to those. But with sickle cell, the patient experience is often to be caught in a perpetual loop of trying to teach staff about what's happening and what treatment the person needs, often at the time the patient is experiencing excruciating pain.
Thank you, for giving way a second. I was very generous. Would he agree with me that this lack of awareness goes all the way through to the research community, where sickle cell is one of the most under-researched illnesses, despite the fact that it has so many different interesting applications around its links in with malaria, its links in with all sorts of other diseases, and that there just simply is not enough research funding which goes into understanding this disease?
I very much agree with the honourable friend's point, and indeed the next finding I was going to cite was a lack of research and innovation in treatment. There's only been one new drug approved in the UK for sickle cell treatment in decades, and that was approved just before our report was published. Now, for each of these findings, we made recommendations in training, compliance with clinical guidelines, reviews of sickle cell treatment in secondary care, communications change, very importantly, a stronger voice for patients in all of this, and in many other areas. And underlying all these individual recommendations and findings, there are some key overarching themes. First of all, these experiences have contributed to a damaging loss of trust among sickle cell patients in the system that's there to help them. Some patients told us they avoided going to hospital at all costs, no matter how serious their crisis, because they found the whole experience so exhausting and debilitating, or as one woman put it, to avoid the mental strain of another battle when she doesn't have the energy to advocate for herself. It cannot be right that people who need help have so little trust that they don't seek that help from the very system of care that's supposed to be there for them. Secondly, there is the unavoidable question of race. Sickle cell is a condition that predominantly, but not exclusively, affects black people. Many patients told us of being treated with suspicion when seeking treatment, of being regarded as troublesome by staff, of being thought of as drug seekers, and of encountering negative and sometimes even hostile attitudes. The principle of racial equality in healthcare is fundamental. No one is seeking to put one group of people above another, but we do want to see equality in healthcare treatment. And right now, with sickle cell, we do not have that. This is completely unacceptable, and following this report, it must be addressed. Thirdly, these findings that we cite in our report are not new. These things have been happening for a long, long time. They've been raised time and time again. And the fact that this is still happening has led to a great deal of anger and frustration among those living with sickle cell and their families. And yet, even though all of this is the case, this might, just might, be a moment of opportunity. Now, why do I say that? Soon after he was appointed, the Secretary of State for Health spoke about the disease of disparity and how the COVID pandemic had exposed a number of long-standing health inequalities, including racial ones. And I very much welcome the Secretary of State's commitment to address these inequalities and his warm welcome of our report on the day it was published. So perhaps this is a moment when we're more aware of health inequalities than we would have been before the pandemic. Maybe this can be a turning point for change. There's no need for this to be a partisan issue. No one is pretending that the findings in our report only began in recent years or under one government. These things have been there for a long time. But perhaps the experience of the pandemic can give us a newfound resolve. Maybe it can mean that this time people do listen. From the Secretary of State and the Department to the NHS in every part of the United Kingdom, we want this report to mark a moment of change in the treatment of sickle cell, to ensure that the issues raised in this report are addressed once and for all, to ensure the training is improved so that staff throughout the system understand and have a knowledge of the condition, to ensure care plans and pain relief protocols are adhered to by both the generalist and the specialist parts of the system, to step up research and innovation in treatment, to restore trust among sickle cell patients, and most of all, to ensure there is equal health treatment for everyone, regardless of the colour of their skin. That is not too much to ask for, but we do not have it at present. So today I appeal to the Minister and the Secretary of State, and indeed my own front bench and the other parties present, to become our allies in this and to work with us. Please don't let this be a lost opportunity. Let us today collectively resolve that we will not have me or another chair of the APPG standing here in a few years' time making exactly the same points that I'm making today. Let's make sure that this time people do listen, that we act on these long-standing failures in the care of people with sickle cell, and that we improve healthcare for people with this condition once and for all. Thank you.
The question is that this House has considered the treatment of sickle cell. Can I just remind members, if they want to speak in the debate, they could rise in the normal way to indicate that. I intend to call the front bench, the Minister and the spokespeople around just over 30 minutes before the end of the debate, whenever that falls. And again, I'll clarify that if there's a vote. And if perhaps I won't put in a time limit, we'll see how we go. If everybody could be respectful of each other's time, we should be able to get everybody in. I call Dr. Greg Clark.
Thank you very much indeed, Mrs Miller. It's a pleasure to serve under your chairmanship. Can I congratulate the right honourable gentleman on securing this debate and for his very powerful speech and indeed his leadership of the APPG. I agree with every word that he's said, and he's right that this is something that should unite all sides of the House. I have the honour to have recently replaced our very good friend, Sir David Amos, as the Conservative officer. As the Conservative officer of the APPG. It is a great responsibility. I do so with pride and look to continue the formidable work that Sir David did for this very important cause, as for so many other causes in this House. The right honourable gentleman has given a comprehensive account of a very powerful and impactful report. And so I just want to highlight a number of its observations and recommendations, drawn as they were from the evidence from people who are living with and, in many cases, have suffered the consequences of family members falling victim to this condition. And the first is this, to reflect the point of inequality that the right honourable gentleman referred to. I have the honour of chairing the Science and Technology Committee, and some members will have read the joint inquiry report that my committee and the Health and Social Care Committee conducted. And one of the chapters of that was the differential impact of COVID on different groups in society. And we made some recommendations as to how we can improve our practice in the future. As the right honourable gentleman said, this applies very much to sickle cell. And in particular, I think what the report emphasises is the need for if I could put it this way, a geographical strategy for the management and response to sickle cell. As the right honourable gentleman said, sickle cell affects disproportionately black people, and we know that the distribution of people of ethnic minorities is not constant, not consistent across the country. And that will mean that there are some places that have an ethnically diverse population who are well used to coping and helping people with sickle cell, others not. But that can't be left to be a matter of chance, because all places have people who will have sickle cell. And so it's very important that we put in place connections between those hospitals and those trusts with deep experience and those that don't, so that they can be accessed immediately when the circumstances arise. And that is a very important commitment that we should make. The opportunity with the establishment of 42 integrated care systems across the NHS is the ideal mechanism for that. The second point I wanted to emphasise in the report, which again the right honourable gentleman touched on, is the differential practice within hospitals. Some disciplines, such as haematology departments, are used to and have very high levels of understanding and indeed expertise in caring for sickle cell patients. But other departments and disciplines within the same hospitals do not, and particularly concerning was the patchy experience of A&E departments, of emergency medicine in this. So it's very important that, and I hope the Minister in her response will point to ways in which the diffusion of knowledge across hospitals, rather than it remaining in silos, is something that can be seized on as a practical outcome of this report. It's something that is clearly attainable. The third thing I wanted to emphasise is the importance of timely pain relief given to people presenting in A&E who have sickle cell. We know that there is an acute need for that pain relief to be administered promptly. The NICE standard is that should be within 30 minutes. But the report was very striking in noting that only 30% of adults, for example, said that they were given pain relief early enough. That is a great concern, that people are suffering great distress during that time with consequences, longer-term consequences for their health. And it concerns me at a time of COVID and entering into the winter, when we know in all of our experiences, constituency MPs, that A&E departments are under particular pressure, that waiting times are longer in A&E departments for reasons that we understand. There is an especial need for emergency medical practitioners to be able to not just spot, but to know how to respond to the very immediate needs of people presenting in A&E departments with sickle cell. And the fourth aspect I would like to emphasise, again, I draw from the work that we did in our COVID inquiry. One of the consequences of COVID and the response to it in hospitals was that, as we know, there are great restrictions on relatives and carers accompanying people into hospitals. We looked in particular at the experience of people with learning disabilities who didn't have people to advocate for them. Now, obviously, in talking about sickle cell, we're not talking about people with learning disabilities, but nevertheless, the assistance that people who are their relatives, loved ones and carers, who, especially at a time of intense pain, are able to communicate the particular needs of the patient at a time when the sufferer may not be able to express themselves, dealing with the pain that they are, is particularly important. And I hope that during the remaining period of this COVID pandemic, this might be recognised, that there are patients that need people to help communicate what their needs are if they're in a state that they can't do it directly themselves. And of course, one means of doing this is through attention being given, being paid to their care plan, so that they should be followed. That would be a way in which we can make sure that the right treatment is given. They are just four of the themes that come out of a very comprehensive and I think powerful report. But there are four aspects that I think have a particular relevance to the immediate weeks and months ahead as we face some difficulties across the NHS. It's very important that as we seek to ensure that COVID doesn't exacerbate inequalities, this potential further source of inequality is attended to and action is taken by the NHS so that the conditions during the weeks ahead can be better than would otherwise take place.
Kate Ossamore.
Thank you, Ms Miller, for calling me. It's a pleasure to serve under your chairmanship. Chairship, I think is a better word. I also want to thank my right honourable friend, the member for Wolverhampton South East, for securing this important debate and for setting out a very strong argument. First of all, our thoughts must be with Evan Smith, who tragically died at North Middlesex Hospital in my constituency, with a determination to prevent further tragically avoidable deaths. The All-Party Group for Sickle Cell and Thalassemia must be given huge credit for putting together the hugely important No One Is Listening report on the failures of sickle cell care and producing an extensive and thought-out list of recommendations. What has clearly been found is that while the details of Evan's case are particularly distressing, this is not just an individual failing of one hospital, but reflects widespread shortcomings in care and a lack of institutional knowledge which has led those with sickle cell to be fearful of receiving secondary care and attending hospitals. Indeed, North Middlesex Hospital itself is situated in an area with a large black population, and compared to the average hospital, should have been well adept at caring for sickle cell patients. Evidence of the dismissal of the pain of sickle cell patients sadly tally with what has been highlighted by other studies into the disparities in treatment of black people by healthcare staff, such as by 5 Times More and their work on black maternal health. I wholeheartedly endorse the recommendations proposed by the all-party group's report. I want to highlight a number of those recommendations. First, the North London Integrated Care System, which my constituency falls under and the North Middlesex Hospital falls under, should develop a concrete plan to improve sickle cell care and share lessons learnt across the entire country. North Middlesex Hospital should also engage with the parents of Evan Smith, Betty and Charles, regarding an appropriate memorial for their son. I would also urge the government to tackle the report's recommendations with the seriousness that it deserves. Knowledge of sickle cell amongst healthcare professionals must be improved by mandating that universities should provide training in sickle cell as part of the curriculum. And Healthcare England should develop a mandatory e-learning module for staff treating sickle cell patients in high prevalence areas. The standard of care must be improved by developing individualised care plans for sickle cell patients, with copies passed on to the patient and all of their carers. And NHS Trust should develop action plans to ensure compliance with the clinical guidelines to deliver pain relief to sickle cell patients within half an hour. Finally, the NHS Race and Health Observatory should undertake a study of sickle cell care, examining how racism affects the experiences of patients and examining the level of prioritisation sickle cell patients are given compared to other conditions. While sickle cell patients advisory groups are flourishing, they should be set up and be given the resources that they need to have an oversight on sickle cell services across all hospitals. There is a lot of work to be done, but the way forward has been set. I also want to add at this point that North Middlesex Hospital has a unit for people who have sickle cell. So what happened to Evan should not have happened. The A&E experience for all patients that have sickle cell needs to be looked at with urgency. I thank you for listening.
Shannon.
Thank you, Madam Chair. And first of all, can I thank you for giving me the opportunity to speak in this issue. I'm the party's health spokesperson, and it's always a pleasure to speak in any health issues. I was just talking to my colleague and friend to the right-hand side there, trying to remember the member for Stephen Pounder, member for Ealing, introduced me and told me about this disease when he was the MP. He and I had a good friendly relationship, but I went to the APPG and sickle cell thing that was happening, through his introduction, I perhaps gained a small bit of knowledge in relation to it. But I want to come here today to speak on behalf of those people who have sickle cell disease. We don't have it in Northern Ireland. Thank the Lord we don't have it in Northern Ireland.
Order.
Just getting started.
In the House. We have a division in the House of
Commons.
I'll
do it all again.
I'm going to suspend the sitting for 15 minutes and 10 minutes for each subsequent vote. But could I encourage members to return to this chamber as soon as possible so we can resume the debate as soon as possible and ensure as many people as possible are able to participate. Thank you. Sitting